immunodeficiency, right? We did autoimmunity, and we did tumor immunology, right? And now this is the transplantation. So transplantation also, again, organ donation is a big event these days, right? And you can think of donors of all the way from blood, which is a tissue, to every organ in the body. So we have to understand, because remember I said that the purpose of immune system is to differentiate between self versus non-self. So your each and every cells have a stamp, they have a barcode, they are your own, right? So we can transfer one part of your body organ to another, it's not going to react. So we can draw blood and give it back to you, it's not going to do anything, right? But if you have to do a organ donation or giving a, what do you call, even blood, you need to match the genetic code, right? So blood is a very common thing, but you name an organ, liver, kidney, right? They talk of heart as well, they talk of what do you call, lungs as well, and then skin graft. So your body is going to identify that as foreign, and body has to kill it. So that's what we want to stop, is the other way around. We want to fool the system so that it takes the organ. So let's understand the immunology part of it, then we'll understand the drugs. Now when you think of a tissue transplantation, so of course we do experiments in animals before we do in humans. So we traditionally have 4 different kind of things: autograft, isograft or syngraft, allograft, and xenograft. So these are the things that possibility wise we can do. Now in an experiment, you can see from here, where is your A? Where is your A here? This is the A. This is what it is. Because in autograft, you take one part of your organ or tissue and give it to the same person, is going to take it, is going to accept. Because you're taking, like for example, if a person gets burned on one side of the hand and you take the skin from the other side, so that's what autografts are. So there would not be any rejection, because this is yours. So that's the ideal situation. Now the other thing is, we call it isograft or syngraft, where we have 2 different animals. In this case it's a mice, but they have been matched for MHC, tissue matching, right? Major histocompatibility complex, right? So you can see, again, it's going to take that, because they are matched at the, so blood group B positive can be given to B positive. So that's the second thing we call iso. The third thing is that if you take a major histocompatible complex, which is A, you want to give it to a B, which is a same species but different animal, is going to reject. Because it has to match at the major, so it's just like mismatched blood. You cannot give it to you because the body is going to kill it. So that is the situation of allograft. And xenograft is basically, you take a mice and give it to rabbit. The animal is different, right? So you take from the mice and give it to rabbit. So you have a mice over here and you want to give it to rabbit, and even if you look for MSC, is of course different, so it's going to reject. What is this?
Take.
Huh?
We take. T-A-K-E.
Okay. Oh, I said take. Oh, take. Okay. No, I said, what's this? Take. Yeah, acceptance, rejection. So does it make sense to you? Because sometimes we want to take from an animal. You must have heard that they're talking about like pig's heart given to human beings, right? So that's where it comes over here, like a xenograft, because the species is different. But they're trying. They are trying. But you can see from here the best scenario is same species, same histocompatibility complex, right? So it's gonna, chances are it will take it. Okay? Now let's see what does the body do. If you take a organ like, let's say, liver, and give it to another person, what will happen? There are two scenarios that can happen. It's called direct recognition, and there is called indirect recognition. The idea is that body has to learn how to identify that. Okay? So what happens in this case is that, let's see, for example, this is a you just take a liver, right, and want to give it to another person, right? And of course it has cell. These cells will have a donor APC, will have a cell which will be a donor APC, antigen-presenting cell, right? And now it has to present to a T cell, right? And the T cell, of course, you can see that it has over here, this one over here is a MHC, and this one over here is a TCR receptor, and this one over here is CD4 or whatever, right? And they want to look at this guy, which is an antigen over here. So this is a typical scenario that we have discussed before. So the host, this is the host T cell, and this is donor. So host T cell recognition, the combination of donor APC and foreign peptide. So it like looks at it, okay, whether it's their own or not. So of course, if it's not its own, it's going to reject it. That's one scenario. The other scenario is where you have a recipient APC. In this case, the antigen is picked by the recipient APC. In this case, it was a donor APC, and then it processes it to present to the host T cell. This is the same in both cases, right? But what is happening in this case is pretty much the same. Same MHC, right? Same CD4, and then again donor-derived peptide. But this peptide is donor-derived. Right? So if it's a donor-derived peptide, what do you think the T cell will do? Yeah. T cell will recognize it, but as a foreign, right? So in this case, where a donor antigen presents an antigen to your T cell, it's got direct recognition. And when the host T cell recognizes the combination with the host MSC, you can see this is host MSC, this one over here. And in this case, this MSC over here is a donor MSC. But the peptide is foreign peptide and foreign peptide. So direct recognition or indirect recognition?
So the difference is if it's donor or host, and you see.
It is a donor APC presenting an antigen with the donor MSC to your T cell. Direct recognition. Indirect is your own antigen presenting cell presents with your own MSC to the. So T cell has two ways of looking at it. Right? But of course, we already know that T cell had this capacity of finding out whether it's foreign or it is what do you call it? Self. But these are scenarios. Why we are talking about that? Because you have to keep in mind that in this case, if there is an MSC-A or MSC-B, so this is called allograft. So in this case, there are alloantigens. Because you've taken the liver from the same species, but of course the MSC is different. So you can see from here, donor-derived peptide. So donor-derived peptide can be presented either by the donor APC or your own APC, but the T cell pretty much is going to react in the same way. Yes?
Yes.
What have you written over here? The recipient, APC?
Presenting process donor graft.
Yeah, donor. Okay. So let's move on to this scenario over here. So these are two clinical aspects. Now, we already talked about, in this case, that we are talking about allograft. This is what we are talking about, right? We are taking from the same species with a different MHC. We are talking about the allograft. Now, what happens is that in immune system, the allograft activation, this is how we get rejection of the graft. Because if your CD4 T cell sees it as foreign, it's going to reject that. Right? It's going to kill it. So CD4 T cell is the major player in this case. So we have a CD T cell in the center, right? And then again, what we are looking at is that how the graft is rejected, and why we are looking at it, because we have to stop that. We want the body to take the graft. So what we are trying to do in this case is we are trying to stop the mechanism and prolong the acceptance. This is the idea, which is actually the opposite of what we used to think. Now, there are possibly at least 3 scenarios. Okay, there are 3 scenarios. So what we do is, for example, if we give an allograft and that is rejected, and then we look at the rejected allograft, right, and we do biopsy of that and see what kind of cell damage was done, because it is rejected, right? So we want to find out what kind of cells are there in the rejected organ. You give a liver or kidney, and kidney is rejected. You take the rejected out, look at the biopsy and see what is happening at cellular level, right? So there are 3 scenarios. Let's talk of first scenario over here. It is called macrophagic rejection, right? The second one is called neutrophilic rejection. And the third one is called eosinophilic rejection. So there are 3 types of rejection that we will see. Okay. So let's talk about the macrophage rejection. So what happens in this case is, when the CD4 T cell, is it native or naive? Who drew that?
It's naive.
Naive, yeah? It's not native, right? It's naive. Naive. Naive is a T cell which has not seen an antigen, is called naive. Okay? So what we see is that this naive T cell, when it sees those donor graft, is going to go and make Th1 type of cells, which are going to make gamma interferon, and gamma interferon is going to recruit macrophages, and these macrophages will kill the tissue. But that's like a pathway, Th1 type pathway, where if you go back and look at the cytokine lecture, you will see this Th1 type, where you have pro-inflammatory cells, and that's what rejectin is. And in this case, you can see that IL-2 was also important, and IL-12 was also important. So what we're trying to do is, in this case, if we find that the macrophage rejection is there, we have to kind of, maneuver these guys over here. We're gonna play with that, so that that doesn't happen, and macrophages are not recruited, and we can prolong the life of a graft. Okay. The other thing is that this one goes for Th2. Actually, let's make this 2. That will be easier, because then just make this 2 and just make 3, because Th1, Th2, and then what is it? What have you written over here? Th17. Th17. Correct? Correct? This is Th17.
Yeah, that's TH17.
TH17, okay. So in this TH2 one, again, you have production of IL-5, and then it's going to recruit eosinophils. And if you remember, eosinophils were also important when we talked about type 1 hypersensitivity reaction. When we said mast cell, basal cell, eosinophils. So eosinophils will come and reject the tissue. Two scenarios, TH1, TH2, and we can play with these players over here, and we can also play with this player if you want to maneuver. So this pretty much is the same, this one is different. Because what will happen if you stop this, then rejection will stop. Just an idea. The third scenario is that we find out that TH17 cells are made by these guys over here, these cytokines, right? And they will need to neutrophils coming into the graft, right? And neutrophils have what you call a killing mechanism, and they will kill the graft. Okay? Now remember I said last week or week before, Nobel Prize was given to the guy who discovered T-Rex. So that's a player. So this T-Rex actually is the one that is stimulated by TGF-beta, and this will influence both. So it can play with that, it can stop that, or it can stop that. So which way we want to go regulate that, we can play with T regulatory. So that's what I said, the T-Rex cells are going to be a big player in the future drugs, because it is regulating, what it is doing, it is inhibiting TH2 cells, or controlling, it's inhibiting this as well, right? And then again, this one can also influence the TH17, both of them can influence TH17. So they can go this way or they can go this way. So all these players that you see over here have to be manipulated to have our donor graft survive. So this is like an overall picture. Okay, so these are the future drugs that we have. Okay? Now let's go to that guy over there. Now what you can see from here, these are the normal organs and tissues that are transplanted. So skin is very common, skin, kidney, liver, heart, lung, bone marrow, cornea, pancreas, and small bowel, right? And these are the clinical situations where we end up doing a transplant. For example, skin, of course, there is a chronic wound, diabetic ulcer, venous ulcer, or burn. In kidney, we have end-stage renal failure. You have to remove it. In liver, we have a cancer of the liver, or biliary atresia, so the biliary ducts are kind of obstructed. Then we have heart, cardiac failure. In lungs, we have advanced pulmonary or cardiopulmonary diseases, lung is not functioning. Bone marrow, we have all these cancers and all these, and so we can do bone marrow graft. So this is like a bone marrow graft, which is a transplant. And then cornea is a blindness. This is basically, it can be done easily. There's not going to be any reaction for that, because cornea is one of those which are immune privileged, and they think that doesn't have a vascular supply, doesn't have lymphatic drainage. So if you take cornea from one person, put to the other, the body is not going to reject it. In pancreas, diabetes is still a big question, right? And what they normally do is that they do the pancreas and kidney transplantation together. They are saying that the success rates are approaching those seen with kidney transplants, but this is, I would say, work in progress, but this is something which is coming up. So what they are saying is that if you have diabetes and your pancreas are not working, there's an option here. Okay? So you can see that organ transplantation is real, and we have this 1, 2, 3, 4, 5, 6, 7, 8, 9, at least 9 different organs that are there, and you can see they have different success rates. It keeps on varying. For example, survival rate, we look at success rate about 2/3 in the first year. Because what normally happens is that when we have a donor transplantation, so we have graft versus host disease. We call GHD, graft versus host disease. When you give an organ, right? So most of the time what happens is, it's there in my notes, if you look at my lecture, so there is if you give it, there is an acute rejection. Right? And then of course there is a chronic rejection. Right? And there is something we call acute on chronic rejection. Right? So this is immediately, this is later, and sometime in chronic rejection you have an acute attack. It's called acute on chronic rejection as well. So that's what normally you have to look at. For example, it says over here, graft now exceed at 1 year, right? And sometime it's more, you can see most they're talking about 1 year. And these are like not a permanent thing. So even if you give a life to a person for 1 or 2 years, I think patient is going to go for that. But survival rate and graft versus host disease, this is what had happened. And these are all what you already learned in pathophysiology. Pathophysiology, which is like acute inflammation, chronic inflammation, acute on chronic inflammation. So all those inflammatory cells are there depending upon how much damage they can cause. Okay? Does that make sense? Okay. Now, let's come on this situation, which is cases of mixed lymphocyte reaction associated with different transplant situation. So what normally happens is that if you look at the genetic makeup, we ran out of genetic makeup of the transplant situation, you will see that the most important thing is HLA, right? And HLA stands for human leukocyte antigen, and what it represents is MHC. MHC, major histocompatibility complex, that we were talking about in animal, in human is HLA. It's the same thing. Okay? So you can see that if we give like tissue between identical twins, which have same HLA identical syngeneic, so there is no treatment required, no reaction. Perfect situation. Right? So this is a mixed lymphocyte reaction we do as a test. Tissue between non-related donor and recipient, because their HLAs are different, allogenic. Well, you can treatment for reacting leukocyte, you don't have to give for reacting, and this reaction intensity depends on the degree of HLA difference between donor and recipient. The more the HLA difference will be, the more severe will be the reaction. That's what we normally say. Okay. The third situation is tissue between non-related donor and, what's the difference between these two? Did you miss something? Everything is the same, they give no treatment, right? Then there is a chance that there is a reaction. And if the donor cells are treated with mitotic inhibitors, the result over here is we'll have one-way MLR, which is mixed reaction. Reaction intensity depends upon the degree of HLA difference, pretty much the same. So there's a slight difference between these two, where we give mitotic inhibitors which are anti-cancer drugs. Okay, and finally, bone marrow. transplantation or tissue grafting to an immunocompetent recipient, you have to go for the HLA difference. Now in this case what we do is the recipient cells are treated with a mitotic inhibitor, and we wanted to make sure that there is no graft versus host reaction. That's what we saw, graft versus host reaction. That's what the whole is there. And this is again one way MLR reaction intensity depends on degree of. So the upshot for all this is that you can see clinically things are not simple. It's not only a matter of giving an organ, because organ has to stay, the whole lymphocyte are going to see it over and over again. So there is a mixed lymphocyte reaction which is associated with this situation. So don't think that if you because one of the things that you can see from here is that as I told you that they just want to make sure that there is no immune response. One of the things that they will do, they will give steroids, because steroids are going to, especially corticosteroids, they're going to kind of dampen the whole immune reaction. Okay, but again, for how long? You can't put it for forever. So there's still a work in progress, and there is still something that they are working on. At the most, you can see in the clinical picture, 1 year, 2 year. Other than cornea, you're just buying time. And again, the challenges remain, and we are looking at all those blockers which are there. And the problem is, if you do a blocker, then it's going to cause other problems as well. For example, how are they going to fight infection, right? So that's a major issue when you give corticosteroids for immunosuppression. Okay? Any questions? Are you guys reading or